Heart failure. Definition. It's a clinical syndrome in which the heart can pump an adequate cardiac output to meet the metabolic needs of the body. Classification: left-sided, right-sided, or both, systolic, diastolic, or both, acute, chronic, acute on top of chronic, low cardiac output, high cardiac output, latent, overt. Etiology: the left-sided heart failure occurs due to whether left atrial failure or left ventricular failure. Left atrial failure from mitral stenosis and myxoma. Left ventricular failure, we have muscle disease, volume, diastolic overload, increased preload, pressure, systolic overload, increased afterload. Muscle disease such as myocarditis, cardiomyopathy, myocardial infarction. Volume, diastolic overload, increased preload due to valvular diseases such as mitral regurg and aortic regurg, congenital diseases such as VSD and PDA, hyperdynamic circulation from anemia, hyperthyroidism, and beriberi disease. Pressure, systolic overload due to increased afterload from aortic stenosis, systemic hypertension, and coarctation of the aorta. Right-sided heart failure from right atrial failure or right ventricular failure. Right atrial failure, tricuspid stenosis and myxoma. Right ventricular failure, muscle disease such as the left, volume diastolic overload or pressure systolic overload. Volume diastolic overload, hyperdynamic circulation, valvular diseases, tricuspid regurg and pulmonary regurg, congenital disease VSD and ASD. Pressure systolic overload, pulmonary hypertension, pulmonary stenosis, pulmonary embolism. The most common four causes at all: ischemic heart diseases, systemic hypertension, valvular heart diseases, and cardiomyopathy. The most common causes of left-sided heart failure are: for systolic heart failure, ischemic heart disease; for diastolic heart failure, systemic hypertension. The most common cause of right-sided heart failure is left-sided heart failure. Diastolic heart failure: in this type of heart failure, the decrease in cardiac output is due to inadequate ventricular filling, not impaired systolic contraction. Most cases are the result of hypertension-induced left ventricular hypertrophy. High cardiac output heart failure is with hyperdynamic circulation such as hyrotoxicosis and anemia. Precipitating factors: infections, iatrogenic, physical emotional stress, pregnancy, delivery, anemia, arrhythmia. Infections such as chest infections and infective endocarditis. Iatrogenic, calcium channel blocker because it's negative inotropic, and cortisone because it leads to salt and water retention. But you need to know that verapamil is very effective in diastolic failure caused by idiopathic hypertrophic cardiomyopathy. Cardiac reserve or compensatory mechanism: the aim is to maintain normal cardiac output, and they are beneficial within limits. If those limits are exceeded, they will aggravate heart failure. We have reflex tachycardia, ventricular dilatation, ventricular hypertrophy, redistribution of blood flow, activation of RAS system, release of natriuretic peptides. Reflex tachycardia due to sympathetic stimulation, ventricular dilatation from volume overload will lead to increase in the length of cardiac fibers and increase the contraction within limit. Starling's law. Ventricular hypertrophy, pressure overload will lead to increase in the thickness of the cardiac muscle fibers, and contraction will increase within limit. Bigger but not better. Redistribution of blood flow from less vital organs such as skin to more vital organs such as brain and heart. Activation of RAS system, hypovolemia, stimulate renin, stimulate angiotensin II, stimulate aldosterone, will lead to salt and water retention and hypervolemia. Release of natriuretic peptides, atrial natriuretic peptides and brain natriuretic peptides. Stretch of fibers will lead to their release, which will lead to vasodilatation and increase in urinary sodium excretion. Before we go to the clinical picture, we need to talk about the other types of heart failure. So we're going to talk about refractory heart failure. Diastolic heart failure: any condition which leads to stiffening of the ventricle, more commonly hypertension, then aortic stenosis, hypertrophic cardiomyopathy, old myocardial infarction, old age, diabetes mellitus. Stiffening occurs due to glycosylation of heart muscle. Diagnosis: the same symptoms and signs of systolic heart failure that we're going to talk about, but the left ventricular ejection fraction is normal. Second approach is by elevated BNP, brain natriuretic peptide level, in the presence of normal ejection fraction. Treatment of the cause, systemic hypertension or ischemic heart diseases. Specific treatment, the same as systolic heart failure that we're going to talk about later, but without using digitalis. Digitalis and other inotropic agents, they have no established place in those patients with relatively normal ejection fraction. ACE inhibitors cause regression of left ventricular hypertrophy, decrease blood pressure, prevent cardiac remodeling. Beta blockers decrease heart rate, decrease blood pressure, decrease oxygen consumption, cause regression of left ventricular hypertrophy, and increase diastolic filling time. Calcium channel blockers such as verapamil, they are effective only in diastolic failure caused by idiopathic hypertrophic cardiomyopathy. Refractory or intractable heart failure, patients don't improve or experience rapid recurrence of symptoms in spite of optimal medical therapy. Etiology, diagnostic error. The case may be pericardial effusion, but it's misdiagnosed. Improper management, inadequate salt restriction or discontinuation of treatment. Presence of precipitating factors such as infection. Presence of cause such as uncontrolled hypertension or aortic stenosis. Terminal cases of heart failure. Treatment, reassess cause. Removal of mechanical factor by valve replacement, removal of precipitating factor, proper management by strict bed rest, salt and water restriction, proper doses of drugs. For terminal cases, continuous IV positive inotropic therapy, CRT, cardiac resynchronization therapy, ICD, implantable cardioverter defibrillator for primary prevention of ventricular tachycardia, mechanical ventilation, and finally cardiac transplantation. It's the treatment of choice in young patients with severe symptoms and with marked low ejection fraction, less than 20% after applying all anti-failure measures. Then we have acute heart failure or acute cardiogenic pulmonary edema. It's due to sudden increase in pulmonary venous pressure, whether by acute left-sided heart failure by myocardial infarction or acute on top of chronic left-sided heart failure, mitral stenosis with aggravating factors such as atrial fibrillation. Clinical picture, severe dyspnea, even at rest, orthopnea, sweating and irritability, sense of impending death, cyanosis, crepitation, cough with frothy pink sputum, and features of the cause, which is myocardial infarction. Differential diagnosis, non-cardiogenic pulmonary edema, ARDS, adult respiratory distress syndrome. Differential diagnosis of acute dyspnea. Treatment, hospitalization in ICU, bed rest in sitting position to decrease venous return, high dose oxygen to correct hypoxia, morphine IV, reduce preload because it's a venodilator and it reduces anxiety, furosemide IV, it decreases pulmonary congestion because it's a venodilator and it leads to diuresis. Vasodilators, sodium nitroprusside IV infusion from 0.5 to 5 mg per kilo per minute, nitroglycerin IV infusion, but the side effect is tolerance. Inotropics, dobutamine beta receptor agonist, positive inotropic and vasodilator, so it's called inodilator. Merinone, phosphodiesterase inhibitor, it's an inodilator. Merinone is preferred to dobutamine because it doesn't act on beta blockers, so it will be beneficial in patients receiving beta blockers in their treatment. And dobutamine also precipitates to ischemic heart diseases. Aminophylline, 250 to 500 mg per IV, slow infusion. Treatment of the cause and precipitating factor, advanced management in refractory conditions. We use mechanical ventilation and mechanical assist devices, intra-aortic balloon counter pulsation. Then we're going to talk about clinical picture of heart failure. It differs according to the type. Left-sided heart failure, we have manifestations of low cardiac output and manifestations of pulmonary congestion. Features of the cause, cardiac signs. Manifestations of low cardiac output, dizziness, headache, syncope, ischemic heart diseases, oliguria, cold, peripheral cyanosis, fatigue, intermittent claudication, low systolic blood pressure, and weak pulse. Manifestations of pulmonary congestion, this is a backward failure, exertional cough, recurrent chest infections, hemoptysis, pleural effusion, pulmonary edema, bilateral basal crepitations, dyspnea, exertional or orthopnea or paroxysmal nocturnal dyspnea or dyspnea at rest. We need to know that low cardiac output manifestations are due to forward failure, while pulmonary congestion are backward failure. Features of the cause, ischemic heart diseases or systemic hypertension. Cardiac signs, we have left ventricular enlargement, tachycardia, gallop on the apex, pulsus alternans, and murmur of functional mitral regurg. Left ventricular enlargement is by localized apex, shifting of the apex outwards and downwards with systolic bulge. Pulsus alternans alternating strong and weak beats in advanced stages. Gallop on the apex due to flappy ventricle. Ventricle gallop equals S3 plus tachycardia. Murmur of functional mitral regurg, pansystolic murmur due to left ventricular dilatation. Right-sided heart failure, manifestations of low cardiac output as stated before, manifestations of systemic congestion, insomnia, lower limb edema, ascites, enlarged soft tender liver, pleural effusion, congested neck veins, sweating on slight activity, diaphoresis due to sympathetic activation. GIT, we have dyspepsia, malabsorption, which lead to cardiac cachexia. Features of the cause, left-sided heart failure and pulmonary hypertension. Cardiac signs, same as the left but without pulsus alternans, right ventricular enlargement, tachycardia, gallop over tricuspid area, and murmur of functional tricuspid regurg. Right ventricular enlargement is by diffuse apex. Apex is shifted outwards. We have left parasternal pulsation, epigastric pulsation, systolic retraction, and wide bare area. Clinical classification, we have New York classification, Framingham classification, and finally ACC or AHA stages of heart failure. New York classification is stage 1, 2, 3, 4. 1. No limitation of physical activity. 2. Slight limitation. 3. Marked limitation. And 4. Severe limitation. Framingham criteria for diagnosis of congestive heart failure, it depends on the presence of 2 major criteria or 1 major with 2 minor criteria. What are the criteria? Major criteria are paroxysmal nocturnal dyspnea, neck vein distension, rales or rhonchi, radiographic cardiomegaly, acute pulmonary edema, S3 gallop, increased central venous pressure more than 16 cm water at the right atrium, hepatojugular reflux, weight loss more than 4.5 kilograms in 5 days due to response to treatment. Minor criteria are hepatosplenomegaly, pleural effusion, dyspnea on ordinary exertion, nocturnal cough, bilateral ankle edema, decrease in vital capacity by 1/3 from maximum recorded, tachycardia, heart rate more than 120 beats per minute. Then we have the ACC-AHA stages of heart failure. Stage 1, high risk for heart failure but without structural heart changes such as diabetes mellitus, hypertension. No symptoms of heart failure. Stage 2, patients with structural heart diseases but no symptoms of heart failure such as left ventricular hypertrophy, chamber enlargement, reduced ejection fraction. Stage 3, clinical manifestations of heart failure. Stage 4, refractory heart failure. Differential diagnosis for left-sided heart failure are the causes of dyspnea and orthopnea, while for right-sided heart failure are COPD, obesity, liver cirrhosis, and pericardial effusion. Complications of heart failure, renal failure, liver cell failure due to associated hepatitis C and cardiac cirrhosis, DVT, pulmonary embolism, acute pulmonary edema, valvular heart diseases, arrhythmia, stroke, syncope, and finally, cardiac cachexia, especially with right-sided heart failure. Investigations, we have X-ray, ECG, echocardiography, cardiac catheterization, other imaging techniques, laboratory, and BNP. BNP, brain natriuretic peptide or ventricular natriuretic peptide, is more than 500 nanogram per liter. It's a very good negative predictive value because if it's normal, heart failure is unlikely to happen. Laboratory, CBC to detect anemia, left and KEFT, left may be impaired due to liver congestion, KEFT or renal function test, kidney function test, may be impaired due to low cardiac output, cardiac enzymes, and acute heart failure to diagnose myocardial infarction. Electrolytes may be impaired due to drugs. Other imaging techniques such as nuclear cardiomyography, CT, MRI may be needed. Cardiac catheterization shows chamber enlargement and detects the cause. X-ray, chamber enlargement, pulmonary congestion, and left-sided heart failure. ECG, usually non-diagnostic, but it can detect the cause such as myocardial infarction and arrhythmia, and it shows chamber enlargement. Then finally, we have the key investigations, echocardiography. It shows chamber enlargement, detects the cause, paradoxical movement of the myocardium, and it measures ejection fraction and shortening fraction. Ejection fraction is stroke volume over end diastolic volume. Normally it's 5 50%. If it's less than 45%, it indicates systolic heart failure. Shortening fraction, it measures a change in diameter between the relaxed state and the constricted state of the left ventricle. It's calculated by left ventricle in diastolic diameter minus left ventricle in systolic diameter over left ventricle in diastolic diameter times 100. Normally it's from 30 to 42%. And this concludes the investigations. Then we're going to discuss treatment. Treatment is divided into treatment of the underlying cause, treatment of precipitating factors such as anemia, general treatment, specific treatment. General treatment: rest, diet, sedation, lifestyle modification. Rest until signs of heart failure disappear, semi-sitting position rather than lying down to decrease venous return. But we have complications of prolonged bed rest such as DVT, bed sores, constipation, psychosis, pulmonary embolism, and retention of urine. Diet: salt restriction is essential, fluid restriction in severe cases, low calories intake, small frequent meals with increasing potassium intake. Sedation such as diazepam. Lifestyle modification: mild exercise may be of value. Specific treatment: medical, interventional, and surgical. Interventional: RCT, cardiac resynchronization therapy, biventricular pacemaker to improve mechanical cardiac function. Cardiac revascularization if reversible ischemia is detected. Surgical for the cause such as CABG, coronary artery bypass graft, or valve replacement. Cardiac assist devices, cardiac transplantation. Then we have the medical treatment. The goal of the medical treatment: decrease preload, decrease afterload, increase myocardial contraction, neurohormonal treatment, and others. Decrease preload by diuretics or venodilators such as nitrates. Decrease afterloads by arterial vasodilators, hydralazine and sodium nitroprusside. Increase myocardial contraction or inotropes, digitalis, beta agonist, dobutamine, merinone, phosphodiesterase inhibitor. Neurohormonal treatment: RAS inhibitors such as ACE inhibitor and ARBs, angiotensin receptor blockers. Aldosterone antagonists such as spironolactone, potassium sparing diuretic. Eplerenone, more specific, more expensive, but is very effective in treatment of heart failure after myocardial infarction. And finally we have beta blockers. Others: minofellin, oxygen therapy. Anticoagulants, especially in patients with atrial fibrillation or with previous history of thromboembolism. Then we have diuretics. The aim of diuretics is just symptomatic relief, no mortality benefit. It increases salt and water excretion, so it decreases blood volume and decreases preload, decreases edema and visceral congestion. We have three types of diuretics: loop diuretics, thiazides, and potassium sparing diuretics. Loop diuretics, they act on loop of Henle, decrease reabsorption of sodium, water, potassium, and chloride, such as furosemide and bumetanide. Furosemide, 40 to 160 mg per day, taken orally, IV, or IM. Thiazides, they act on distal tubules, decrease reabsorption of the same items, sodium, potassium, chlorine, water. Then, such as hydrochlorothiazide and chlorothalidone. Hydrochlorothiazide, 25 to 100 mg per day. Potassium sparing diuretic, spironolactone, it can be combined with Lasix or thiazide to avoid hypokalemia. Side effects of Lasix and thiazides: for hypo, for hyper. Hypokalemia, hypovolemia, hyponatremia, hypocholeremic alkalosis. Hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia occurs only in thiazides because it saves calcium while Lasix lose calcium. Then we have ototoxicity and nephrotoxicity in Lasix, hyperkalemia and gynecomastia in spironolactone. In heart failure, Lasix is better than thiazides, better given in the morning and better to be combined with ACE inhibitors. Vasodilators, they are classified into arteriolar, venous, or both. Arteriolar reduce afterload, such as hydralazine and diazoxide. Venous reduce preload, such as nitrates, and both include ACE inhibitors and sodium nitroprusside. ACE inhibitors are now the cornerstone of treatment of heart failure. They improve mortality, morbidity, relieve symptoms, and prevent their occurrence. And this is very important MCQ note. Before we go to the inotropic agents, we need to know the side effects of ACE inhibitors, which include skin rash, dry cough, hyperkalemia, and first dose phenomena. The cough occurs due to increase in bradykinin because it decreases its inactivation, which is a vasodilator. ACE inhibitors include captopril, which is short-acting, half to 2 tablets 3 times per day, while we have long-acting ACE inhibitors such as enalapril, which is taken by 1 tablet per day, or ramipril or lisinopril. Vasodilators, diazoxide, its side effect is hyperglycemia. Sodium nitroprusside, its side effect is cyanide toxicity. Hydralazine side effects are precipitation of angina, lupus-like syndrome, and reflex tachycardia, so it's always administered in combination with beta blockers. Angiotensin receptor blockers, or ARBs, such as losartan, valsartan, irbesartan, the side effects are same to ACE inhibitors but without cough. Then we're going to return to talk about the inotropic agents. Inotropic agents such as digoxin, dobutamine, and dobutamine is preferred to digoxin, of course. Then we have merinone. Merinone is much more preferred than dobutamine because dobutamine precipitates ischemic heart disease, and we have to take beta blockers also in treatment. So merinone doesn't act on beta receptors such as dobutamine. And then we're gonna go to talk about digoxin or digitalis. Its action, it increases contractility of the ventricles, increases excitability, decreases conductivity and heart rate by direct action and vagal stimulation. On ECG, we have sagging, depression of ST segment. Mechanism of action, it inhibits sodium-potassium ATPase or sodium-potassium pump. It increases intracellular sodium, increasing intracellular calcium, increasing muscular contraction by sliding of actin over myosin. Indications, it was previously used in chronic heart failure, but its use is limited nowadays. It should be used as the first line of treatment in patients with heart failure and atrial fibrillation. It can be of no benefit or lead to life-threatening toxicity in cases of heart failure with the following underlying heart diseases such as isolated mitral stenosis, coronary heart diseases, pulmonary diseases, and right ventricular failure, pericardial tamponade and constrictive pericarditis, and finally hypertrophic cardiomyopathy, and those with diastolic dysfunction due to decreased ventricular compliance. Contraindications, we have absolute contraindications and relative contraindications. Absolute contraindications are digitalis toxicity, ventricular tachycardia. Relative contraindications are peptic ulcer, partial heart block, nodal rhythm. Administration, digitalization to reach optimum therapeutic level, 2 tablets daily for 5 days orally. Maintenance dose compensates for daily urinary excretion, 0.5 to 1 tablets daily orally. Preparations are digoxin, digitoxin, and ubain. Ubain is taken IV. Digoxin excreted mainly by the kidney. Digitoxin metabolized mainly in the liver. Digitalis toxicity. Precipitating factors: renal failure, old age, hypokalemia, hypomagnesemia, hypothyroidism, hypothermia, hypercalcemia, hypernatremia, alkalosis, acidosis, myocardial ischemia, drugs such as quinidine, verapamil, amiodarone, and sympathomimetics. Both acidosis and myocardial ischemia suppress the sodium-potassium pump. Dr. Mowafy has written alkalosis leads to hypokalemia. I'm not responsible for this because KK. Clinical picture, non-cardiac and cardiac. Cardiac manifestations are increased excitability leading to arrhythmia and decreasing the AV node conduction leading to heart block. This is the most life-threatening manifestations. Any arrhythmia can occur except for sinus tachycardia and type 2 second-degree heart block. Non-cardiac manifestations are gynecomastia, yellow-green vision, photophobia, psychosis, headache, paresthesia, confusion, anorexia, nausea, and vomiting. And GIT manifestations are the earliest symptoms for digitalis toxicity. Treatment: stop digitalis, stop diuretics, give potassium in cases of hypokalemia, replace magnesium loss. Digitalis antibodies, digibind, binds to intravascular digitalis. It's used when the patient is hemodynamically unstable or with life-threatening arrhythmia. Symptomatic treatment: atropine for heart block, antiarrhythmic drugs, phenytoin and lidocaine. Manage hyperkalemia as usual, except we don't use calcium gluconate, we give magnesium sulfate. To avoid toxicity, we decrease the dose, we perform drug holiday and routine estimation of serum level of digitalis. Normally it's from 0.5 to 2 nanogram per milliliter. Then, beta blockers. Historically, beta blockers were contraindicated in heart failure due to their negative inotropic effect, but recently they are indicated because they were found to improve mortality, morbidity, prevent arrhythmia, prevent or partially reverse progressive left ventricular dilatation, decreases blood pressure and oxygen consumption, and renin. Only 3 drugs are used in the treatment of heart failure: metoprolol, bisoprolol, and carvedilol. Metoprolol is second-generation beta-1 blocker. Carvedilol is third-generation beta blocker. Start with low doses, then gradual increase. Finally, we have Entresto, which is a combination between sacubitril and valsartan. Sacubitril is neprilysin inhibitor. Neprilysin is responsible for the degradation of ANP and BNP natriuretic peptides. Valsartan is angiotensin II receptor blocker. It's indicated to reduce the risk of cardiovascular death and hospitalization for heart failure in patients with chronic heart failure. The recommended starting dose of Entresto is 100 mg twice daily. Double the dose after 2 to 4 weeks to the target maintenance dose of 200 mg twice daily, as tolerated by the patient. Contraindications are patients with hypersensitivity to any component, patients with history of angioedema related to previous ACE inhibitor or anti-angiotensin receptor blocker therapy, with concomitant use of ACE inhibitors. Don't administer within 36 hours of switching to or from an ACE inhibitor, with concomitant use of aliskiren, renin antagonist. And this concludes our chapter for heart failure.